Welcome everyone to the Canadian Nurses Association's webinar series, Progress in Practice. This webinar is entitled Addressing Health Inequities During the COVID-19 Pandemic Through Leadership and Competence in System Transformation. This session is being recorded for nurses who are unable to participate today. My name is Elizabeth Marin. I am the Member and Network Specialist here at CNA, and I'll be hosting the webinar today. At the end of the presentation, we will answer your questions, which you can type in the Q&A box by clicking on the Q&A button in the toolbar at the bottom of your screen. We will address as many questions as time allows. The certificate of participation will be emailed to you along with the link to a recording of this webinar. And now a little bit about our presenters, Catherine Baxter and Ruth Schofield. Catherine Baxter has worked in nursing education for over 20 years in teaching and administrative positions. She has experience in curriculum design, accreditation, and program evaluation. Catherine is currently an assistant professor at Brandon University and a member of the Community Health Nurses of Canada Leadership Standing Committee. Her current research is centered around the phenomenon of work. Specific interests include workforce migration, moral distress, and the health of Canadian workers. Ruth Schofield is an experienced nursing professor in community health nursing at McMaster University. Her research focuses on community health nursing, nursing education, and mental health and housing. Ruth has over 23 years of public health nursing practice experience in various positions and programs. She is currently the chair of Community Health Nurses of Canada's Leadership Standing Committee. Over to you, Catherine and Ruth.
Welcome to this webinar. And as mentioned, we are going to be looking at addressing health inequities and moral distress among community health nurses during the COVID-19 pandemic. This study is a partnership between Community Health Nurses of Canada, Leadership Standing Committee, Brandon University, and the National Collaborating Center for Determinants of Health. Next slide. We'd like to recognize the members of the Leadership Standing Committee, as you'll see on your one side there, the list of names there, and also the research team. And these are all the individuals. And the research team is members from the Standing Committee. Next slide, please. So the Community Health Nurses of Canada is a national organization for community health registered nurses to advance practice and to improve the health of Canadians, and that is our mission. One of the standing committees is this Leadership Standing Committee. And one of the purposes of the Standing Committee is to develop and implement a continuing education program on leadership for community health nurses. And hence, one of our things that we really wanted to look at was this study to really understand how nurses are being leaders, community health nurses are being leaders during their experience in the COVID pandemic. So this webinar is an opportunity for the Standing Committee to really achieve some of these objectives of being a hub for professional development and knowledge translation and supporting the evidence-informed practice, cultural humility and integration of the competencies, leadership competencies in practice. Next slide.
Thank you, Ruth. So thank you for this opportunity to share this research with you today. And really where this research began was looking at the media accounts, the accounts of nurses, and importantly, a survey that was initially done by the Association of Regulated Nurses in Manitoba that surveyed community health nurses in the province. And that survey showed high levels of stress, heightened inequities that community health nurses were seeing, and certainly they were telling us about insufficient resources. Certainly the information that we heard made us feel that there was likely going to be similar things across the country. And so the leadership committee decided that a national survey would be important to undertake. And we wanted to focus on the concept of inequities and how those inequities might contribute to moral conflict and moral distress in community health nurses. And certainly we were seeing major sources of moral conflict in that preliminary data. So when we look has that it arises when nurses are unable to act according to their moral judgment. They feel they know the right thing to do, but the system, structures, or personal limitations make it nearly impossible to pursue the right course of action. Next slide, please. So this was what we studied. The purpose was to explore how health inequities amongst client populations contribute to feelings of moral distress, to identify solutions to address health inequities amongst client populations, and to identify those the leadership capacity is needed to enact those solutions. Next slide. So just by a little bit about the survey and the participants. So it was an online survey. It was distributed through membership nurses who are members of the Community Health Nurses of Canada and individual provincial networks. Individuals were asked to pass the survey on to individuals that would meet the criteria. So it was a snowball sample. The link to the survey was available for 6 weeks in June and July of 2021. And the significance of that is when we're looking at the moral conflicts that were identified, it's important to know where in the COVID-19 pandemic trajectory we were. So we were at the end of the third wave, and vaccine rollout was certainly had begun. But there wasn't enough at that point vaccine for everybody. So we were still prioritizing vaccine delivery. And that certainly came out in the findings. So that's when the survey was carried out. 270 individuals opened the link, but a total of 245 completed the survey. Next slide, please. We had good representation across the country. We saw the majority of survey participants came from Ontario. We had no representation, unfortunately, from Quebec or from the Northern Territories. Next slide, please. In terms of who the participants were, 239 of the 245 self-identified as being female, 3 male, and 3 other. We had 17 participants, or 7% of our sample, that identified as Indigenous, First Nations, or Métis, and another 8% identified as a visible minority. So not a very diverse sample in the participants. Next slide, please. I think this slide is really interesting because it shows and I think puts some context around some of the information that we received. So if you look at the dark orange line at the bottom, you'll see the number of individuals that had worked as a community health nurse for less than 1.5 years, which meant that the only time they had worked as a community health nurse was during the COVID-19 pandemic. And that likely has contributed certainly to our findings in some way. You'll see though by the light yellow line or light orange line at the top, as you progress down the slide, that individuals had lots of nursing experience, but many of them were certainly new to the role as community health nurse. Next slide, please. In terms of the practice settings that were represented, 65% of participants identified that they were working in public health, 17% in a primary care setting, 6% in a home health setting, and 12% in other. And other included in Ontario, the Local Health Integration Network, First Nations and Inuit Health, First Nations communities or on reserve, occupational health settings, parish nurses, educational settings, or with the armed forces. Next slide, please. In terms of geographic region, where people were from, 62% came from urban areas and 38% from rural. So we had good representation from rural Canada. And in those in urban areas, 52% were in urban inner city and 48% were in urban other. So a large number of people working in the inner city urban areas. Next slide, please. So this slide is a summary of really what came out of the data in relation to the sense of moral distress. And we're going to just talk a little bit about this slide and then focus the remaining part of the presentation on the solutions and the leadership competencies that were identified. So if we look at the top, we see that we have the CNA Code of Ethics, and we have the public health, ethical dimensions in public health as the context behind how community health and public health nurses practice. So those are the ethical frameworks that are always present and guiding their decisions. So the first thing we saw were some COVID-19 pandemic constraints. And the constraints that they identified quantitatively were certainly lack of time and not being able to provide the necessary care as a result of that. Heavy workloads, which delayed the provision of necessary care, and having to prioritize the needs of COVID individuals with COVID rather, over other populations. Qualitatively, similar themes arose, although they gave us more depth to that. The nurses told us that workload, heavy workloads was certainly a source of constraint. The need to continuously refocus their work, redeployments to other settings impacted how they can deliver care to individuals. The conditions of everyday living, so poor housing situations, overcrowded housing, perhaps homeless populations, situations that created difficult situations for people to uphold public health restrictions and requirements. The public health orders themselves, they were very black and white. So this is the continuously changing public health orders, as well as the inflexibility in those public health orders was a challenge for nurses to work under. When you're working with someone who is homeless, it's hard to find places for them to self-isolate. And government policies didn't keep up right away with the public health orders. So having to isolate, but there was no paid sick leave for individuals who didn't have sick benefits through work, or the shelters that were eventually established for individuals who were homeless were not available in the very first stages. And the last one was reactive responses. So the idea that we were continuously reacting to the situation, we were not able to actually get ahead of it and be proactive. So those COVID-19 constraints led to, I'm just going to write this down for a second. Those COVID-19 pandemic constraints led to an amplification of existing inequities. And those inequities are things that were already present, but we saw more of during the COVID-19 pandemic. So the three areas that were specifically identified was the disproportionate impact of persons in situations of marginalization, the widening of the digital divide. Certainly everything went online, and that was great if you had access to good internet and smart devices, but that wasn't the case for so many individuals. And the accessibility of services, both again, rural and urban divide, but also when immunization clinics were being set up, initially they weren't accessible to a lot of inner city urban populations. So these amplification of inequities led to the sense of moral conflict. And within the data, 8 areas were identified as sources of moral conflict. So unsafe and inadequate isolation conditions was one. Another was the unmet needs, so not being able to address all the needs that clients had. The constantly changing and uncertain landscape was a source of when public health orders were changing, unsure of whether the changes were based on best evidence or other things. Threats to quality of care. This came in primarily in relation to the immunization clinics, and many of those clinics were staffed by immunizers with limited training, and there was concern that the public health standards for immunization was not always being upheld. Negative impact of public health orders on certain populations. So individuals who were having to self-isolate, but maybe were in abusive relationships, or overcrowding, or again, the impact on those that were homeless. One size doesn't fit all. So there was a sense that some of the public health orders and the conflict relating to the public health orders meant that everybody had to be treated the same. And yet there were individual situations that created challenges. And so that inability to use clinical judgment and alter those. And the last one was it was never enough. They felt that even though they were working very long hours, that it was never enough for them to be able to accomplish all of the work that had to be done. And the last piece of this was compounding factors. And so the compounding factors are things that contributed on top of the moral conflict to make the situation worse. And those compounding factors were things like pre-pandemic constraints. So we had a nursing shortage going into the pandemic that greatly impacted on the resources that were available during it. Leadership, management, and communication, and that comes up loudly in the solutions. When communication was poor, that contributed to distress. Having to hear all day long the pain and the distress of others was exhausting, and also phoning people who were angry or who were in denial about the requirements also created distress. And then there were personal and family factors. So nurses also felt that they were working on COVID all day, and they were working on all of the care that needed to be provided. And then they would go home and they were worried about their families. They were also isolated from loved ones in other provinces. They were fearful, especially in the early stages, that they would bring the virus home. So they had all of those personal factors that added additional stress on top of that moral conflict. And all of that led to moral distress. So in the poll that you've just completed, 93% of you have indicated that you have experienced moral distress during the pandemic, and 7% indicated that you haven't. So let's see how those compare to what we saw with the community health nurses. Next slide, please. So within the actual data that we received, 80% of our participants indicated that they were experiencing moral distress during the pandemic. 75% of those participants indicated that that distress was related to inequities. So high levels, high percentage numbers of moral distress. And certainly the high level that is indicated by your poll today tells us that this is something that people are experiencing. Next slide, please. If we look at the level of moral distress as it compared to pre-pandemic levels, 80% again said that their level of moral distress was higher. So they were experiencing more than previous. I think the next little moral distress thermometer. So people were actually given a little thermometer and asked to indicate the level of moral distress on that. This is what is alarming. So 20% felt uncomfortable in the level of distress. 20% found it very distressing. 25% found it intense. And 8% reported that it was the worst possible. So very high levels of distress. Next slide, please. So we do know that moral distress is associated with, in the literature, things like compassion fatigue, exhaustion, and burnout. We weren't looking for this in our research, but certainly some of the quotes and some of the individuals certainly gave us indication that they were experiencing those things. They used the words exhaustion, they used the words burnout. But importantly, so moral distress certainly can lead to feelings of anger, frustration, and guilt. We know that, but it can also be a catalyst for growth and advocacy. And that's what we're going to focus the rest of this presentation on, really looking at the solutions that came forward and how these community health nurses used their sense of moral distress and were able to focus that to identify solutions going forward. Next slide, please. So if we look at these solutions, we're going to go through each of these themes individually, and how we're going to do it is I'm going to talk a little bit about the theme, and then at the end, Ruth is going to provide you with some of the quotes that demonstrate some. We have an awful lot of data, so we're only going to select a few key thoughts, but we will try and highlight ones that really show what nurses are telling us. Next slide, please. So let's look at the first one. The first one is advance health equity. And this came out in terms of solutions as it was threaded through all the data and certainly was at the forefront of the stories that nurses were telling us. And how they wanted us to do that, and some solutions that they thought we could bring forward. First of all, we need to start by addressing existing inequities. So they were amplified, but we need to do a better job of addressing those that currently exist. We need to look at implementing policies and mobilizing supports to address the disproportionate impact of public health orders on individuals and populations in situations of marginalization. So recognizing that public health orders do not have an equal impact, and how can we ensure going forward that public health orders and supports address that disproportionate impact. To be sure to provide trauma-informed, culturally safe and accessible services. To maintain core public health programming so that we don't have to stop everything, that we're able to continue to provide care to individuals with addictions, or provide care to individuals who require follow-up for STIs, that all that postpartum care, breastfeeding, support, all of those services can continue. Incorporate principles of social justice and equity in pandemic planning, response, and recovery. To engage frontline experts, so to ask people who know on the ground and engage them in decision-making. Population-focused planning, so planning that focuses on populations and not includes all individuals. New approaches and ensuring sufficiency of resources.
And so just to hear the voice of the nurses, some of them, I'm just going to share some quotes. So quote, many individuals are dealing with a housing crisis, need affordable housing. That's number one. Provincial childcare would be number two. Need to support moms and families who are unable to afford childcare, preventing them from going to school and or work. We need to look at how we deliver care and service, and also make some key policy changes like basic income, paid sick time, to decrease inequities. This would go a long way in reducing the moral distress that those of us working in the system experience as a result of the current inadequate policies, which increase the inequities and thus contribute to our moral distress. One last quote I want to share. Dr. Adeline Falk-Raphael talks about the trombone slide of nursing, where nurses have an opportunity to witness social injustice downstream in our work with clients, and then advocate for health equity upstream at the system level. This balance is essential to reduce moral distress and give nurses a feeling of making a big picture difference to address health inequities and improve the lives of individuals in the communities we serve. Next slide.
So the second theme was expand community relationships and partnerships. And some of the things that solutions that were identified as ways to do this certainly is to recognize the importance of existing relationships. So public health nurses work very closely with communities and establish long-lasting relationships. And during the pandemic, it's important to recognize that those relationships exist. The need to break down silos between different parts of the health system, but also different parts of society in general, so that we're working together and communicating. To develop intersectoral, intra and interprofessional partnerships, loud and clear that we need to work together, that we can't do this alone. To engage individuals and communities in the planning. So this is to engage the people whose lives are impacted, who know their own circumstances, and to include them in the planning. To reach out to marginalized populations so that we are ensuring that the solutions that we come up with are ones that target the right things. And to engage our religious and community leaders in planning.
So here's a quote that a nurse gave: continue to liaison as closely as possible with community partners in order to reassure staff that some client support is still being provided by others, and to work with the partners to plan a coordinated and robust response when the pandemic and restrictions ease. Another quote: advocating for change by engaging others and developing coalitions with the community as well as the healthcare system as a whole. Next slide.
So the third theme was to strengthen leadership and management. And both of these came across. So the leadership skills are important, but so are the management skills. So focusing on leadership for health. So when we're looking at leadership, we're looking at how to address equity and inequities, how to accomplish equity and address inequities. To ensure our planning is proactive versus reactive. So looking ahead and having plans in place so that we're not trying to react to things as we go. Ensuring clear, open, and transparent communication across organizations and within organizations. To provide support and guidance to staff, so to support people as they're refocusing and redeploying, and adequate guidance in ensuring that they have the supports necessary to do their jobs as they are now articulated to them. To listen and act upon the concerns of community health nurses. So to listen to what frontline staff are saying and to try and address those concerns and act on them. To bring in evidence-informed decision-making, recognizing that the evidence was all very new and it was emerging as we went, but ensuring that decisions that we make are based on the best evidence that's available at that time. And to create a climate of respect and equity within organizations and also with those that we work with. And to foster nurse empowerment, to allow nurses to exercise some clinical judgment in situations.
And a quote here is: engage others from frontline staff have the answer to a lot of the issues experienced in the clinical care setting. By allowing frontline staff the autonomy to direct change will, in the end, be better for client care, increase morale, and decrease moral distress. Another quote: Leadership, which uses evidence-based information and the people doing the work and gaining valuable education of social justice and health equity and public health, who seems to be rather ignored for their opinion in this pandemic, but would act as extremely valuable resources in developing solutions. Next slide.
So the next theme for solutions was to ensure quality care through professional nursing practice. And this came through in a great many places in the data, and certainly was something that came forward as one of the biggest constraints and areas that we need to improve upon going forward. So the sense that we need to address the nursing shortage, and I think every province right now is trying to do that. But when we started the pandemic, that shortage was in place. To value nursing expertise and competence. And within that, it's to recognize what is the role of community health nurses and public health nursing practice, and what can they bring to the response that is unique. And in doing so, we also want to uphold the professional standards of nursing practice. So when we're looking at creating immunization clinics or perhaps hiring contract workers to do contact tracing, we're making sure that when we're doing that, we're not in any way jeopardizing quality of care, and that standards of nursing practice are being maintained. To increase funding, and really that increase in funding is necessary so that we can protect core services. So we don't have to stop providing every other aspect of care in order to meet the needs of the pandemic. And to address the lack of surge capacity in the system so that we can respond if we need to beef up our public health resources, we have the ability to do that. And then to provide adequate education and support to public health nurses.
And a quote, more nurses so that those that have been working literally every day since this started can get a break. More nurses so that programs can catch up so that the needs of the community can be met once again. More nurses so that we can stop putting Band-Aids on the problems and stop limping along so that we can actually get back to the primary care that is our primary purpose. Another quote, to start to have some staff time discussions and planning that is focused on non-COVID care and initiatives. COVID does require time and resources, but we cannot ignore all the other health issues. We need to restart programs and support that are non-COVID supports, especially in the areas of harm reduction, chronic disease management, and mental health. Next slide.
So the last theme for the solutions was to enhance safety, health, and wellness for nurses. And there was a real sense that what we need to do, the amount of distress that was expressed by nurses in relation to concerns about personal protective equipment and protocols in the first wave, especially of the pandemic, that sense that we need to uphold that precautionary principle. And when we don't know what we're dealing with, we provide the highest level of protection possible. To bolster workplace supports, to make sure that staff themselves have the ability to access supports at work and perhaps through debriefing sessions or other services. And also for the need for nurses themselves to practice self-care. This has been a very long process, and so that idea that they're in this for the long run, and how are they going to ensure their own health and wellness.
So a quote is, creating support groups for public health nurses to discuss their experiences and strategies to not only address the situation they're encountering, but also to be encouraged, to encourage self-care. Another quote, be self-aware in order to combat the moral distress we experience. Next slide. And we're just asked you to complete a poll. And we can see that there's a mixed view there. There's about 52% that are familiar with the public health leadership competencies and 48 that are not. And I think what we could have slightly changed that question, because in fact, the question we asked the nurses, because this was going to community health nurses, not just public health nurses, was the LEADS framework that is also known broadly by others. So what we want to just now share with you is just a little bit further now in the questions we asked related to leadership. So the nurses, as you heard, shared a number of strategies of solutions to address inequity. And just to highlight, we use this framework, and just as I mentioned previously, the LEADS framework, which many may be aware of, was the framework that we used. And so the LEADS framework is the one on your left that actually follows the acronym: lead self, engage others, achieve results, develop coalitions, and system transformation. And so that you may be more familiar with. In 2015, with Public Health Agency of Canada funding, CHNC, in partnership with Manitoba Public Health leaders and also SciFi, which are the Canadian Institute for Public Health Inspectors, worked together to develop the leadership competencies for public health practice in Canada. Our environmental scan resonated well with the LEADS framework to inform the domains of the competencies, and hence we have the same domains. As you can see, but what is different is the order of the domains is different than the LEADS framework that use the acronym to inform the order. The public health competencies use these domains, as I mentioned, and it was in hierarchy of public health leadership in practice. So we viewed leadership, and I think the important thing that was alluded to earlier in the results is that we heard not only about leadership and management because they're related. We are distinguishing them as being different. So we will focus more on the leadership. So what you can see here, what the public health leaderships identified in the order of the domains was system transformation, achieve results, lead self, engage others, and develop coalitions. So just change the order, but it reflects public health practice. So the next, we'll do the next slide and the poll, and I'll continue talking. So in what we then asked the nurses in the study, while we asked the nurses to identify what leadership domain they saw themselves in achieving the solution. So we gave them this list, and they then needed to select, and they could select more than one for them to consider their own leadership. And so as what we're presenting are, again, preliminary findings, so I think that's important to note. But what you can see is that they did identify system transformation, and we had 99, and then engage others, 77, develop coalition, 53, lead self, 29, and achieve results, 23. So you can see that, in fact, they changed the order again too, and what they perceived were the leadership domains that would most enable them to achieve the solutions they identified and we discussed earlier. So we're going to walk through, not unlike, so as we're waiting for the results, we'll see what we've heard from you, and we'll move on to the next slide, system transformation. And so not unlike what we did with the previous results around solutions, we then looked at the information because we asked the nurses to then elaborate on their choice of domains to achieve the solution. And so this is where we then got some qualitative information that really showed us what they meant and how the various domains of leadership would reflect their competence in where they wanted to go. So it's interesting, you can see the results here that have just come in. Likewise, system transformation became very much the choice that was the first choice at 51%. And I'm just trying to move this over so I can see. And then achieve results was 13, which is consistent with what these nurses in the study said. They had it lower. Then lead self, engage others, and develop coalitions. So it's very interesting that they're very similar to the results that we saw in our study. So you could see that there's a number of indicators related to each of these domains of competencies, and just the distinction between the LEADS framework focuses on capacities and the public health leadership competencies are focused on competencies, knowledge, skills, and attitudes. So the analysis that you're going to see at this point is related to the public health leadership competency framework. We haven't done the LEADS, and we asked nurses to choose one of those as they were reflecting and responding to the question. So that data has not been analyzed yet from the lens of the LEADS capacity framework. So based on the public health leadership competencies, they identified these 6 were the most common competencies that they could relate to. So it was about the understanding of how to guide change, a system thinking perspective, demonstrated innovation and creativity, advocate and guide change, demonstrate and drive motivation, and demonstrate forward thinking.
So a few quotes that demonstrate how they would like to address this through system transformation. So quote, "We cannot with our few resources do this work in isolation of our communities and partners," end quote. Quote, "Structural oppression, power, and privilege are at the root cause of moral distress. Systemic change is required for growth. Addressing inequities is multifactorial and requires effort in every domain in order to achieve lasting results," end quote. Quote, "We need new systems in place to address these inequities and need to gather as communities to support these inequities. Our current systems are requiring remodeling in order not to marginalize populations." And the final quote, "Develop a plan of action that will best alleviate the current ageism brought on by society that allows us to treat our elderly like nothing more than a burden, educate individuals within communities, and encourage communities to get more involved in care. It will take a system transformation to address post-COVID in community health. It will take a pan-Canadian system of transformation," end of quote. Next slide, please.
So I think because our time is rather short, what we'll do is just highlight the next few slides because we want to give some time for questions coming from you as well. And also we have had a few questions that have been shared with us. So the next domain of leadership was engage others. And you can see here, they identified a number of competencies that would enable them to be leaders and to address health inequity. in terms of working with others, multiple professions, respect and rapport and trust needed, empowering, enabling others, sharing power, mobilizing others, recognizing, encouraging, contributing others, and communicating clearly. So I'm wondering, we'll just hold on the quotes, Kathy, because I'm a little worried about the time, if you don't mind. So the next leadership domain was the develop coalitions, and they identified these 5 competencies that in fact would enable them to work with leaders in the community and work with others in the general community. Then lead self, the next slide, as we go on. Yeah, thanks, Elizabeth. And this was really talking about they recognized themselves needed to be accountable, demonstrate emotional intelligence, demonstrate self-awareness and demonstrate reflectivity and flexibility in response to criticism. Those were important competencies in leadership. And the very last one around achieve results to really address inequities as understanding the power and influence and that were critical in terms of mobilizing people, garnering support and momentum for the public health vision, and champion the principles of public health. And really, yet at the same time, be leaders in developing programs that were effective and successful. So that ends it. Sorry we needed to move through, but we really want to hear from you. So thank you for this opportunity to share, but above all, we want to thank the community health nurses who gave their time in all this period of time. And this was not a short survey, as you can appreciate, but were willing to share their stories.
Thank you for your presentation, Catherine and Ruth. Before we move on to the Q&A, I'm going to bring up a couple of poll questions on the usefulness of today's webinar. And while you answer that, we'll move on to the Q&A. Genevieve Curie will facilitate the Q&A portion of the webinar. And you can submit your questions in the Q&A box by clicking on the button in the toolbar at the bottom of your screen. Over to you, Genevieve.
Thank you. Good morning, good afternoon, everyone. So I'm Genevieve Curry. I'm also on the CHNC Leadership Standing Committee. So just to highlight some comments that came up in the chat, Ruth and Kathy. Someone made the comment that perhaps the higher level today of 93% indicating they had experienced moral distress is related to the ongoing nature of the pandemic, with certainly no end in sight at this point. Mm-hmm. Another comment that it was alarming to hear the amount of distress that was experienced by community health nurses, but it certainly has validated people's own experience who are on this particular webinar. And someone else mentioned the importance of self-care and not, we shouldn't invalidate its importance for others, and so that this research highlighted that. So I'm just going to ask you a question as well. That came up when people registered for the webinar. So one of the participants asked, how can electronic systems be used to support collecting evidence about health inequities? Kathy or Ruth?
Go ahead, Kathy.
Okay, I can answer that. So I think in terms of, it's a very good question, and I'm not sure that we actually have an answer for it, except to say of its importance. And I think a lot of what we heard about the need to communicate and to have communication across the system. And I think having our systems talk to each other and having our databases that can collect this information is incredibly important. So I'm not sure that we have an answer to that question. I do think, however, we can definitely support its need and the need to address that and to ensure that we are using technology to communicate better across the country and, in fact, across the world.
Thank you, Kathy. So we have a question that's come up in the Q&A. And I'll just read it out to you. I understand the emphasis on system transformation as a key leadership domain needed to address inequities. However, frontline nurses mostly have a limited ability to transform systems. It is not in their reach of their practice, and they face a lot of barriers to change organizational practices. How can this be resolved?
Wow, that's a loaded question.
That is.
That's a very interesting one, and it's a great question because it's fascinating as a standing committee within Community Health Nurses of Canada. System transformation continues to come up, and we, as you can see, these competencies were developed in 2015, and that's been the priority of our continuing ed. Has been focused on system transformation, so it's very timely and very interesting. It emerged again in this study. So it is saying something that we're not quite good at that yet as community health nurses. So probably the answer is we need to work on it together. What are the tools that we can support each other to address system transformation? So I think it is something that perhaps some of us are involved with at multiple layers, but how are we leaders? And even leaders at the point of care are still being leaders. And so leaders at a system level, we know that's all part of our standards. When we think of clients, we think of individuals, families, communities, populations, and systems. So it's part of our work. It's part of expected practice. So it is probably something that we need to really hear from you. What do you think would we need to do to support that development in system transformation? Because it's not a simple thing. You're right. So how do we do it? So we'd love to hear more from you about that and how we can create some continuing ed. And this will be an outcome of this study to continue to look at how can we support community health nurses to address this expected area that we have in the context of wherever we are working, not at particular levels, but any level in our organization. So great question.
Another question in the chat, any thoughts on the moral distress experienced due to the vaccinated, unvaccinated situation?
So the data that we have certainly shares some of the difficulty, and in the one heading that we looked at, the sense of distress of hearing the distress of others. The full title of that is looking at also addressing anger and denial. And we presented in depth that information at a previous session a couple of weeks ago. But within that theme, certainly nurses told us how challenging it is to phone individuals and be either confronted with denial that COVID's not real, or this is not for me, or this isn't necessary, or anger that somebody has exposed them to this, and that whole debate about vaccination versus unvaccinated individuals. So we heard it, and we heard that as a source. Certainly one of those compounding factors is certainly, we heard that loud and clear.
Thank you, Kathy. In the survey data, was there a differentiation of roles and experiences of moral conflict distress? For example, nurses at the point of care and those who are in formal leadership roles.
So that's a very good question, and one we will likely be able to answer a few months from now, but not now. As Ruth indicated, this data is still fairly new to us, and so there's all sorts of sub-analysis that we hope to be able to do. So that is certainly looking at within the capability of the data set to be able to look at were different groups impacted differently, for instance, years of experience. What about all of those community health nurses that have only worked during the pandemic? We haven't done that sub-analysis yet, but a really good question, and certainly something that we hope to be able to do a deeper dive into the data so that we can get a glimpse into the answers, maybe not definitively, but certainly to have a look at what the data is telling us in that perspective.
Another comment, building on the previous question, which was about public health nurses, community health nurses' role in system transformation.
Mhm.
What can community health nursing leaders do if they see the public health goals and directions as not compatible with equity or nursing values and directions?
Mhm. I'd like to give that back to some of the public health leaders that are on this call. And I know there's some, as I looked at the list of participants, so it'd be interesting to see how they can, because but maybe I can start with some ideas, but I'd love to hear, and I know we've only got a few minutes, so I believe there are some leadership initiatives starting that community health nurses have been asked to contribute. So if there are opportunities as we go through this, well, I was going to say post-pandemic, but I don't think I can say that right now with the Omicron coming forward with us. But we at least are having more conversations about post-recovery, and I think we can be some voice in that. And I think it would be really important for nurses, whether in public health or community, anywhere in community health, speaking up and saying what we heard in the study. Listen to us. We have some options. So if there's opportunities to respond to reports, because we do know Public Health Agency of Canada is looking at hearing from various sectors in terms of where do we go in post-recovery. And so I think there are opportunities, but if there's others in the audience who've got some ideas, either put your ideas in the chat box, or these are some of the things that perhaps raise your question and we can respond to them, because I recognize our time is short and perhaps I'm not able to completely answer the question at this point because we've run out of time. But there is an opportunity. If you'd like some follow-up, we will have that opportunity to follow up. If you put your name in the chat box with your email address, we would be pleased to follow up with you and give you some more, a fuller response.
Thank you, Ruth. So I think we only have time for one more question. I'll just say it really quickly. When I think of equity, particularly in these times, I think of digital virtual access to care services, hardware, software, internet access learning for clients, and along the same lines, digital competencies for nurses, healthcare providers. Do you see a place for digital competency development for nurses above and beyond current entry to practice digital competencies? Also, what about digital access for clients and families? Hardware is expensive and internet access is not universal throughout Canada.
It's interesting. That's a very important and critical question. It's sort of like we're in a transition within our profession. And I think you've labeled a very critical one. And I had the opportunity to be with Cousin recently in this past week, and that was raised again. That very question was raised. How are you preparing nurses to use digital resources in care, not just in how we manage our data and our information, but how we do it in care? Those are very good questions, and I think it really lends itself to some real thought in terms of how do we keep the client in this story, and how do we demonstrate our expected practices within community health nursing. And it certainly raises, looking at our standards, who are just current too, and I shouldn't say current, in terms of revisions in 2019, that probably in a few years when we do update them, we're going to definitely have to strengthen those areas. So excellent question.
So in the interest of time, I'm going to stop it there because Elizabeth has some comments she'd like to make, but I'd like to thank everyone for attending the webinar. And as Ruth said, if you have any feedback or would like a response from the panel, please put your name and email address in the chat box. That'd be very helpful. Elizabeth, over to you.
Thank you again, Catherine and Ruth, for your presentation today. We hope this session stimulated your thinking about addressing health inequities during the pandemic. This webinar was recorded and will be made available on our YouTube channel, hopefully by next week. And thank you for your participation today. Enjoy the rest of your day.